Shannon Loy. Janet?
Thank you so much, Ben. I really appreciate all that you've done to prepare for today and your perfect welcoming voice as people enter the arena with us. We are so pleased to have you with us today. My name is Shannon Royce. It's my privilege to be the director here at the Center for Faith and Opportunity Initiatives at Health and Human Services. That's sort of a long name, so we tend to go by the Partnership Center. It's our privilege here to serve the American people and promote the efforts of faith and community providers around the United States. For those who are not familiar with our work, our office was founded in 2001 by George W. Bush, President Bush, and continued through President Obama and now into the term of President Trump. We've worked under 3 different names, but the Partnership Center's mission has stayed the same, and that is to strengthen the capacity of faith and community organizations and leaders to address the priorities within HHS. It's my joy today to welcome my friend and new colleague, Dr. Lisa Miller. Dr. Miller is with Columbia University Spirituality and Mind Body Spirit Institute, and she is co-hosting this entire webinar series with us. It has been a real joy to get to know her over this last year and plan for these efforts together, and I want to open up for her to make a few opening remarks, and then we'll deal with a few housekeeping items we need to cover. So Dr. Miller?
Welcome. Thank you, Shannon. It has been a great joy and a privilege to collaborate closely with you and your office. The Partnership Center is a magnificently innovative and forward-thinking colleague, and it has really been a joy to co-conceive this webinar series. The Spirituality Mind Body Institute is 10 years old, rooted at Columbia University Teachers College. We are founded on science. I am foremost a clinical scientist, and we have now worked much like our partners here to help seed a more spiritually supportive and aware society. So this is a natural partnership. This webinar series was lovingly conceived over a full year of thinking. Who were the leading innovators across our country in partnership models? Who were the front runners creating models, evidence-based models that are now being shared with you for your adaptation, your consideration? Our speakers show a glimpse of what is possible, what is actually more effective, and ultimately, in the richness of their presentations, how this can be done so that you too can, on your own terms, in your own way, integrate this vision into your own system. Shannon, take it away.
Thank you so much. I knew you would give that the perfect intro. Being the scientist that you are, it's been such a joy to partner with you. So before we begin our webinar, I need to touch on a few technical things just to help this be a successful experience for everyone involved. This is an educational webinar, off the record, and not intended for press purposes. So if you are a member of the press, we ask that you allow us to connect you with our public affairs office at the end of the webinar. If you're having difficulty hearing us, we find that some people have more success by calling into the number provided at the bottom of your screen by Zoom. So if you're having trouble hearing, you might try calling in directly. We will be sending out a recording of today's webinar to everyone who registered to join us today. So we are hopeful that you will view this again and that you'll share it with others who are interested in these topics and concerns. That email will come in the next day or two, and so we hope you'll be watching for that. We do have a full program today, and so we'll get to as many questions as we can at the end of our time together. So if you'll just go to the bottom of the screen and add your questions there in the Q&A feature, then we will be able to get to those things. So want to introduce you to our 2 speakers. We will introduce one and allow him to speak, introduce our second speaker and have him share with us. And then we will go to a time of Q&A exchange with Dr. Miller and I leading that conversation. Our first speaker today will be Dr. Ted Hamilton. Dr. Hamilton is Chief Mission Integration Officer and Senior Vice President of Mission and Ministry for AdventHealth. In this role, he provides direction and oversight of mission and ministry, developing and implementing strategy, and incorporating mission across all the organization's inpatient and outpatient areas. A graduate of Loma Linda University School of Medicine, Dr. Hamilton completed his family practice training at Florida Hospital. He also earned a master's degree in business administration from the Rollins College Crummer Graduate School of Business. That's almost as much of a mouthful as our name. Dr. Hamilton is an active participant in AdventHealth's Community Involvement Program, which supports several Central Florida nonprofits and has served on the boards of Orlando Healthcare Center for the Homeless, Shepherd's Hope, and Second Harvest Food Banks of Central Florida. Dr. Hamilton, it's a joy to have you with us today, and we'll turn the floor over to you.
Dr. Hamilton, can you hear us? We need you to unmute your line, please.
Can you hear me now?
Now we can hear you, sir. And go ahead and
all right.
share your screen.
It was the fall of 2013 when the telephone rang in my office, and the voice on the other end of the phone was that of Dr. Harold Koenig. Many of you are familiar with Dr. Koenig and his work. He is a practicing geriatric psychiatrist at Duke University. More importantly, Dr. Koenig's work over the past 25 years and his true professional passion has been to do research and to compile the existing research on the relationship between spirituality and health, between religion and health. Dr. Koenig had a request for me. He said that the evidence is really overwhelming. It's certainly very compelling that there is a relationship between spirituality and health. He said, however, it's been difficult to get doctors to begin to incorporate this idea of spiritual wholeness into medical practice. And he said, I'm wondering if your company, then called Adventist Health System, today AdventHealth, would be interested in collaborating with me and the Templeton Foundation on a research study to see if we can be successful in changing doctors' attitudes and practices towards spirituality in health. Well, that was an intriguing opportunity. We vetted that with leading doctors at our institution, with our administrators, and ultimately reached a decision that this was an opportunity that we simply couldn't turn down. The research study that Dr. Koenig envisioned would be a year-long study that would involve a number of doctors and a total of 3 surveys, one at the very beginning, one about 3 months later, and one at the end of the study, to determine if we had been successful in changing attitudes and practices towards incorporating these issues into practice. We began to sign up doctors. There was no remuneration. There was nothing other than volunteering, because this seemed like important work. We recruited doctors for about 7 months to volunteer for this study, and at the end of 7 months, to my amazement, we had 540 doctors who had registered for the study. Now, we did have some attrition over the year of the study. About 15% of the doctors dropped out, but we had 450 who completed the entire study. I told Dr. Koenig that I had 3 wishes for this study. One was that the study itself would be successful. The second was that somehow in this process that doctors themselves who participated in the study would be blessed for having done so. And my third wish was that this might open the doors to a wider implementation of something like this around our company. Well, we did the study, and the results of our study led to, let's see, I'm having trouble getting this to click here. Next slide, there we go. The study itself led to the publication of 4 papers in the peer-reviewed academic literature. The major finding of the study was that more doctors, frankly, than I ever anticipated, were willing to incorporate this into their practice. Frankly, we didn't change many attitudes, but what we did change was practices, as doctors began to get a comfort level with participating in this program. To support the doctors, we ultimately built in a call center so that if a patient answered questions, screening questions, in a way that indicated there might be an issue, the doctor could refer them to our call center for further care. At the end of the study, our company decided that this had been so successful that we wanted to take it company-wide in the outpatient setting. We devised 3 questions. Do you have someone who loves and cares for you? Obviously, that's a pretty good clinical question too, in that we know that patients who do not have someone who loves and cares for them are less likely to visit their physician, less likely to get their medications filled, more likely to show up in the emergency room, more likely to be admitted to the hospital. The second question was, do you have a source of joy in your life? And the third, do you have a sense of peace today? If a patient answers no to any of those 3 questions, if the physician or provider is comfortable doing so, they can manage this right in the office. If for whatever reason they don't have time or they don't feel competent to deal with that, they can refer that patient to our e-spiritual care call center. We hired 38 clinical mission integration team members to call on physicians' offices to orient them to the program, to call in the office periodically, make sure that the referral system was working as it should, to support that practice in any way possible. The amazing thing about that to me was that within a very short period of time, these clinical mission integration team members actually became an active spiritual resource to the practices themselves, to the physicians, to the staff who worked in those offices. So we've been at this now for just over 2 years, and I want to share with you some of our numbers. We now have almost 1,900 physicians and/or practices that are participating in what we now call clinical mission integration, incorporating this spiritual wholeness screening into their practice. Over 5 million patients in the outpatient setting have been screened to date, and we are well over 20,000 referrals to our call center. Those referrals become part of the electronic medical record, and the physician receives a consultation report back to the medical record so that the provider or physician knows what was done and what the recommendations are. This was so successful after about 1.5 years that we decided to take this to the inpatient setting as well. So today, the 1,000 or so patients that are admitted to AdventHealth hospitals across the country will have these 3 questions asked of them as part of admission. Do you have someone who loves and cares for you? Do you have a source of joy in your life? Do you have a sense of peace today? COVID has certainly brought all sorts of challenges to our hospitals around the country, but it's also brought opportunity. We've had many patients now who embrace telehealth, many more than we ever did prior to COVID. So we've had to adapt, and we have been able to incorporate now our spiritual wholeness screening into the telehealth setting. So my 3 wishes. The first was that the study would be a success, and it succeeded beyond anything that I could have imagined. The second was that it would be a blessing to physicians, and certainly that's turned out to be the case. As our team members visit the physician's office, it's not at all unusual for them to be asked to stay a bit and talk with either a physician or one of their staff about a challenge in their life that we can be of benefit to. And finally, it has opened the doors to a much wider ministry across our company, as thousands of patients have been ministered to. Just today, I checked to see what our numbers are, and our numbers for yesterday were 72, I think, referrals to our outpatient call center just in one day. That's a brief overview of our spiritual wholeness screening clinical mission integration program, and I will pause for now and turn to the next presenter.
Thank you so much, Dr. Hamilton. Actually, Ben is still working to get Dr. Post online with us. So if I could have Dr. Miller join us, we'll just share in a few questions with you while we wait for Dr. Post to join.
Shannon,
Dr. Miller, let me turn to you first.
Oh, Shannon, Dr. Post is ready whenever you guys are. I think we'll be able to turn to him after we hear from Lisa real quick.
Perfect. Are you ready to turn to Dr. Post, Lisa?
Sure, and then we can engage in discussion.
Perfect, perfect. I don't see him on my screen, Ben. I'm sorry, I didn't know he had joined us. So Dr. Stephen Post, we are...
Can you just, Shannon, before you introduce Dr. Post, can we have Dr. Post come on the camera? So Dr. Post, if you can start your video. Dr. Post, if you can, I invited you to.
Well, I do have some questions for Dr. Hamilton, if I may. Shall I? Yeah.
Sure, go ahead, Lisa, since we're waiting for Dr. Post.
Dr. Hamilton, thank you for such an illuminating and powerful presentation. And most of all, thank you for your innovative work and the tremendous amount of spiritual support you give patients. Suffering, as you convey so beautifully, often has a spiritual dimension and begs for spiritual support. And it can even be in our times of suffering that we deepen our spiritual connection, and that can be a time of a pivot point or deepening. There's so many questions you brought to mind, but the first I might ask you if you could expand a bit on the type of exchange that happens in the call center, what spiritual support looks like in the system you've created.
Sure. We have 3 full-time individuals who man our call center, or woman our call center, and they're all have pastoral and chaplaincy training, so they're well equipped to do this work. Typically, they will open a conversation with a patient by saying, my name is Ted, and I'm calling on behalf of Dr. Jones. We know that you visited Dr. Jones the other day, and he referred you to us to talk about some of the issues that might be going on in your life. And we wonder if you could spend a few minutes with us. That generally starts the conversation. And within a short period of time, it becomes a rather intimate and close over the telephone line conversation. One of the most common things that we find is people who are lonely, frankly, often shut in or don't have family or friends that are close, are not sufficiently independent that they're able to attend their faith community services. And more than once, we've had a person on the line say, "What a blessing, I've been to church today," at the end of that call. So that's kind of the way they go. They may be 15 minutes, they may be 35 minutes. And if we're not able to resolve the situation immediately, we try to refer them to their own faith community ongoingly, but we're more than willing to call another couple or 3 times and chat with them until we can have a sense that things have sorted out and they're feeling better.
It sounds that at once you offer immediate spiritual support and where it might be indicated a bridge to ongoing spiritual community. It sounds to me, tell us again, how many hospitals are in your system?
We have today, I think it's 49. It could be 48 or it could be 50. It changes a little bit, but we are right at the 50 mark. We're in 9 different states. About half of our hospitals are here across the belt of Florida, but we are also in Texas and Colorado and Kansas and Illinois, and then in some of the southern Appalachian states as well.
Because what strikes me in your model is how very inclusive it is. That as a patient, I might come in from any faith tradition or perhaps outside a faith tradition and still get just the right spiritual support for me. And I think that inclusiveness, where you locate the point of choice in the patient for spiritual support seeking, is beautifully architected. I think we have Dr. Post. So shall we hear from Dr. Post, and then we'll all come back together for discussion.
That sounds perfect. So Dr. Post, I can see you and I can hear you. Welcome.
I'm happy to be here. I had a little technological challenge. But
you know, I'm a person of faith, and sometimes I think those are the moments when we know there's something really big happening. So we're so excited to have you with us today. Let me do a formal introduction of you, and that'll give you a moment to catch a breath from the stress of what you have just dealt with in this last couple of minutes.
Well, and then you can, good.
Exactly, then you can do your presentation. So Dr. Stephen Post is a leader in research on the benefits of providing compassionate care in relation to improved patient outcomes and clinician well-being. Dr. Post has taught at several schools and since 2008 has been at Stony Brook, where he is founding director of the Center for Medical Humanities, Compassionate Care, and Bioethics. The center was selected in 2011 for special institutional excellence by the Liaison Committee on Medical Education of the AMA and AAMC accrediting body, the only humanities and ethics entity in American medical school history to receive this distinction. Dr. Post is the recipient of multiple awards and author of more than 300 journal articles in top academic journals. Dr. Post, we're so glad to have you join us today. Even with the technical challenges, we're thrilled to hear your presentation. I'll turn it over to you.
Well, thank you. I am smiling, and good early afternoon to everybody out there. I wish I could see your faces. It's so much of an honor to be speaking. I'll try to keep this brief, but I'm going to talk about building a healthcare community, and there's a little subtitle here, 2 Spiritual Axes. I had a conversation with Dr. Lisa Miller, and we wondered what really I should focus on. And she thought, well, you know, the way you've been able to integrate spirituality at Stony Brook Medical Center would be a good approach. And so I will ask Ben, next slide. Okay, so I think of spirituality in terms of a vertical axis. There's a little image of Saint Benedict. Next slide. And if I were going to recommend to anybody a great book to read about every aspect of the engagement of religion and medicine clinically and in all ways, it would be Jeff Levin's brand new book, Religion and Medicine. It's absolutely phenomenal. There's never been anything like it, and he's been at this his entire life. So if you're interested in getting something that can really contribute to your knowledge, this is the book. Okay, next. Okay, and that's just a little comment on the book, but it's got everything. Next. Okay, so this is just to start off with an image. I think images are important. It's a Chagall stained glass window that is in the United Nations, and a lot of people are familiar with it. And he was an amazing artist who had a real spiritual sense. He was Jewish, but he was also very eclectic and interested in the symbols of all the world's religions. Next. Ben? Okay. This is something from Chagall that I think is so interesting. He had run away from home. He was in St. Petersburg. He was sketching on the sidewalks for donations. He was sleeping in the alley. And then one night he's sleeping next to a very large construction worker. He suddenly sees a blue light descend into the alleyway. He feels completely uplifted by this. He sees a blue angel. Next slide, Ben. Ben? Okay. And so I won't go through all this because it's a little difficult, but at any rate, he sees an angel fluttering, and then the angel ascends, leaving blue behind. And Ben, the next slide. Okay, so the next day, interestingly, he paints his first painting. You think of Chagall as a great painter. He was just sketching up until this point. And his first painting was the Apparition, which is an image of a blue angel. And there's Chagall. You know, you can go, next slide. Chagall was a perfectly enjoyable person. He had no psychiatric difficulties, but he had this experience and it shaped his life. Okay, Ben, let's go. Next one. And then other people have had these experiences too. Auden, the great poet who wrote The Age of Anxiety and coined that term for our era, he speaks about being on a lawn at Oxford with some friends. And lo and behold, there's nothing special going on. They're not drinking, they're just having some conversation. And he just feels this incredible energy, and he can't quite put his finger on it, but after that experience, he has this profound sense of the love of his neighbor, that somehow or another, his neighbor is absolutely invaluable, of infinite worth, and it changed his life. So that was an experience that he had. The next slide, Ben. I want to go pretty quick on these slides. Sir John Templeton, writing, this is the philanthropist, about how he had experienced and felt the reality of an unlimited love that was the most basic creative force in the universe. This is quoting him. And he thought that our fleeting human emotions are in fact mere glimpses of God's perfect love. Next slide. Then we're going to go real quick on these slides. That's Sir John. Next slide. And he would write things about unlimited love and agape love that were really very, very profound. So he asked a friend of mine, Matt Lee, who is now at Harvard, to do a national survey on the experience of divine love. You can go forward, Ben. Yeah. And so we did a survey of adult Americans, and it was really exciting because what we found out, we were using Lynn Underwood's daily spiritual experience scale, at least in part, Of these 1,208 men and women across the U.S., 8 of 10 Americans reported that they felt God's love directly and that it increased their compassion for others. Next, Ben. So almost half, 45% of all Americans feel God's love at least once a day, and 8 out of 10 have this experience at least once in a while. 84% of the respondents acknowledged that they, quote, experience God's love as the greatest power in the universe. This is incredible. 83 indicate that they feel God's love increasing their compassion for others. 53 claim that this is an experience they have on most days or even more often, which is unbelievable. Almost half, 48% of the respondents who had a strong sense of purpose directly experienced God's love daily or more. Well, it goes on. We'll go to the next slide. And we wrote a book about this for Oxford. Margaret Paloma, who studies prayer, and Matt and myself, called The Heart of Religion with Oxford. And it just presents these unbelievably powerful facts about everyday American mysticism, if you will. Next slide. Okay, so there's that vertical axis that we pay attention to, and then the horizontal axis. This is just an image from Van Gogh of the Good Samaritan. Next slide. Horizontal, I mean between people. Ben? Ben? Okay, so in everything we do in this medical center, we have partnerships with clinical pastoral care in all of our community building, because now we're really talking about building communities that can support compassionate care, whether that's in ethics consultations, in every department across the hospital. We talk about professional boundaries. You know, Robert Frost said, something there is that does not love a wall. So we have just low waist-high fences that allow a lot of communication between our clinicians and pastoral care. It's a very smooth relationship. Next, Ben. And we have this center which works off this model where we focus on the illness experience. We do this with clinicians, we do it with students, we do it with even patients themselves. We have literature weeks, we read When Breath Becomes Air. We want people to be sensitive to illness experience, and then the virtues, the empathic virtues that sensitivity generally elicits. And then hopefully that contributes to compassionate care. So that's our model. And next slide, Ben. Okay, so let me just start. This is a book that Sir John Templeton wrote, The Worldwide Laws of Life. He passed away some years ago, actually in 2008. Next slide. And I had the chance to write the foreword to this, so I've been all around signing Sir John's book on his behalf. Keep going, Ben. We're going to move really quickly through these. And these are his laws of life, and they're all about human interactions. So gratitude, kindness, hope, and so forth, forgiveness, perseverance. Those are the things that he thought were necessary for meaningful interpersonal spirituality. And then go one more slide, Ben. So I've been applying these to various medical contexts. This is an image of Hopewell, which is in Mesopotamia, Ohio, out near the Pennsylvania border. That's Amish country. And these are people with bipolar disorder, or in many cases also with schizophrenia, who are mildly treated. They do have to be medicated by clinicians who come in from the Cleveland Clinic generally, but they're on very low doses because they practice moral treatment. They're close to nature. They milk the cows. They bale the hay, and they have small groups that spend a week or sometimes 2 weeks focusing in on a particular positive psychological virtue like kindness or forgiveness or creativity. And in these kinds of circles of trust, they find a lot of therapeutic value. Go on, Ben. And it's been very successful. So I'm very committed to bringing positive psychology into medical contexts and do it quite a bit. I had the opportunity way back in 1997 to introduce with Arthur SCHWARTZ, Sir John Templeton, to Marty Seligman, because Sir John wanted science to start paying attention to his laws of life. And that's actually where the first Summer Institute for Positive Psychology kicked off. And the book that some of you know, Character, Strengths, and Virtues, emanated from that. But it was absolutely amazing because Sir John found someone who he thought could orchestrate a scientific investigation of these classical principles of great spiritual wisdom. Next slide, Ben. And a couple of years later, we actually had a conference in Washington where most of the institutes from the NIH came to talk about what we were calling unlimited love, or about compassionate love. That's George Valiant there in the middle, and Lynn Underwood on the left, who developed that widely used daily spiritual experience scale. Keep going, Ben. I'm going to float through these very quickly. This is an image of Hopewell because it's a 350-acre farm that a group of people purchased from the Amish. It's really quite amazing. It's hopewell.cc if you're interested in going online. I wrote a book called Why Good Things Happen to Good People. Again, this is just horizontal spirituality, how to live a longer, healthier, happier life by the simple act of giving, with Jill Niemark. It's all about these principles, these laws of life, and the science behind them, and why they're healthy and in general, and how they contribute to flourishing life. Okay, next, Ben. Okay, and this is kind of the scale. I call it the wheel of love. So love, I define love, I even do this in lectures in the medical school and with clinical departments. When the happiness and security of another is as real to you as your own, you love that person. It's a pretty commonsensical definition. It doesn't rely on archaic languages, but it makes a lot of sense. When the happiness and security of another is as real to you as your own, you love that person. But people don't like to talk so much about love, so it's all the manifestations of love that really count. So compassion, gratitude, loyalty, listening, celebration. We did a clap out the other day for an organ donor. Just doing these kinds of activities that are expressions of love in particular given circumstances. M. Scott Peck and I together coined the term carefrontation because we didn't like confrontation, but sometimes you do have to address people and try to get them back on track, consistent with really what they want to be anyway. Next slide. Attentive listening, love sucks. This is just an image of the house. You know, sometimes I have to acknowledge that these kinds of themes are a little bit difficult to really get ingrained in a healthcare system, because everybody's under pressure for revenue units. They are struggling with all kinds of pressures. But if you work at it, it can happen. And I'll tell you how that can be the case. Keep going, Ben. You're going to really flip right through these. So we work on a model. I borrowed a little bit from Parker Palmer, the Philadelphia Quaker, circles of trust. So we have these small circles, 6 to 8 people, no more. We community build with them. We have reflection rounds in all the clerkships, in all the residencies for every department, in every clinical department with actual attendings themselves. We bring people together in small circles and we let them reflect on resilience, on meaning, on purpose, on why it is that they came into medicine to begin with, and mostly on the human side of their experience. Next slide. They love to be able to reflect on their encounters. They're not talking about patients, but they're talking about how they themselves felt about a particular experience. the human side of their lives that they usually would just bring out in the parking lot at night and leave it just out in the cold. Or maybe they'd wake up their significant other at midnight and say, guess what happened to me today? And of course, that's a hard thing to respond to. But it's been incredibly powerful, and we built these across an institution of probably 3,000 people. Let's continue on, Ben. Okay. And these are some of the themes that come up, if I can even see that. A derisive joke. For example, a medical student was in medicine in clerkship and heard a derisive joke within earshot of a patient and just stood there. He asked himself, should I even laugh? He didn't laugh. Should I smile? No. He just stood there passively. And a little later on, the nurse approached him and said, you know, I noticed you handled yourself very well. Why don't you approach the team and tell them how you felt about this humiliation that was going on? And he did that diplomatically. And they, of course, recognized that they were really not acting appropriately, and they apologized to him. And he felt in that process that his own integrity and his own professional identity were greatly strengthened and enhanced. Good role models, not so good role models. Coping with serious error. There was a nurse several years ago in the NICU who made a mistake that resulted in the death of an infant, and she didn't have an opportunity to really process this well. This was in New York, not here at Stony Brook, and she killed herself. What's my purpose in medicine? Requests for suboptimal care. Moral injury. That's a much better term than burnout, I think. Should they call us heroes? This last week we had a whole series of events about how people felt as healthcare professionals and suddenly being called heroes because we were such an epicenter for the COVID. And actually, almost without any exception, they did not like being referred to as heroes. They felt they were just doing their job. But these are deep human questions that people need to process. And if we can bring that into the community, instead of leaving it at home or leaving it at midnight in the bed, if we can bring it into the community and let people really reflect on this and form relationships around these experiences, it's incredibly powerful. Now, let's keep going. Ben? Okay, so Schwartz rounds. We do a lot of Schwartz rounds. I think a lot of you know what Schwartz rounds are. I won't describe them in detail, but you can go to the Schwartz Center website and see them. But you just basically have the clinician, maybe the nurse, maybe the social worker, only for 3 or 4 minutes each, talking about how they perceived and experienced something. Like, for example, the death of an adolescent who had refused chemotherapy because he'd been watching videos that taught him that this was all terrible when it probably would have healed him. So these kinds of things are very difficult for all healthcare professionals to manage. And so then right away, this goes out into an audience, maybe 70 or 80 people, and they reflect, they have a conversation about similar experiences they've had. And it sometimes brings tears to people's eyes. In this particular instance I'm referring to, the pediatric oncologist did cry because she said, you know, if only I had called Child Protective Services in Albany, where I had a little clout, they would have said, look, this 16-year-old boy, you should treat him despite his resistance. But she didn't do that. She went with the local office and they said, well, he's 16, he'll be 17, he'll be 18. You need to respect his autonomy. So these things are very painful and they stick with people for years and years and years. We have cases that are 10 or 15 years old and it still brings professionals to tears. Let's go on. Okay, Ben, looking at this. Next slide, okay. So this is what people say. All our professionals, our students, they feel that they matter because we care enough about them to set up structures to listen to their voices and to listen to the human side of their experience. I think it is a nice way to unwind and talk about issues that have been bothering us over time. I think it's very useful. It's spaced out very well. It's not too frequent and it goes on. But basically, people really do appreciate this. And Academic Medicine wrote a nice article or published a nice article that said that when you have SCHWARTZ rounds and these kinds of small community experiences, SCHWARTZ rounds are bigger than reflection rounds. It actually demonstrably increases feelings of compassion toward patients and families. So you can't tell any physician or any nurse or any clinical social worker to be more compassionate. It just doesn't work. It's just silly, you know. But what you can do is you can form a compassionate community. All virtues begin with community. That's from Aristotle to Stanley Hauerwas. You can't get away from that. So you have to form a community of people who share a commitment to certain virtues and strengths, and they share this with one another, and then together in teams, they can exude this in the presence of patients. So we'll go on to the next slide here. And of course, when you can create a community of compassionate care, it benefits the clinicians. There are thousands of articles about this, that clinicians themselves benefit, but so do the patients and so do the systems themselves, because their reputations are enhanced and they do better. There's a nice book called Compassionomics, The Revolutionary Scientific Evidence That Caring Makes a Difference. I do recommend it to you. It's split into 3 parts: the benefits to clinicians, the benefits to patients, and we know from all the work of Harold Koenig and Jeff Levin and so many others about what those benefits are, especially in the context of chronic illness and adherence to difficult treatments. Sample topics in SCHWARTZ rounds: running on empty. What happens to compassion during an opioid epidemic? Moral injury. Love for a quote-unquote difficult patient. Sticking with a non-adherent patient. Humiliated by being kind. Remember the old movie, The Doctor, with William Hurt? It's so interesting because the kindest doctor in the system is actually ridiculed by his colleagues, who are not better surgeons than he is. He's an ENT surgeon, but they ridicule him because they just think he's too kind. So there is that side of human experience. What I've tried to say here is that you know, at Stony Brook, what we've done reasonably successfully is we've paid attention to that vertical side, the spiritual side, and also this more horizontal side of spirituality. So what you might call relational spirituality, and they're both equally important. Let's go on to another slide. I love to give talks about the Golden Rule. This is a great old painting by Norman Rockwell. It shows that the interface between the vertical and the horizontal blurs. So these are people who are meditating on the positive version of the Golden Rule. How can we help others as we would want to be helped ourselves? And you see they're all in a very peaceful, you can go, don't go forward yet quite, Ben. You can go back to that image that we had. Okay. You know, they're asking themselves, they're going through a mental exercise. How can we contribute to the lives of others? And in that process, of course, they're in a more serene state of mind. They're more peaceful. They're probably activating their mesolimbic pathway. They may be feeling very tranquil, and so they're de-stressed, and in that very action, neurologically, it turns off hostility, bitterness, anger. Keep your stress response turned on for forever, in a protracted way that's very damaging. But then in the middle, you can see the halo, the white halo, the circle in the middle of it's with the, I guess, the rabbi's beard, and goes around the toddler and then up on the other side. And what Rockwell said, because I actually heard him talk about this when I was a young kid, and he was still alive, work of contributing in love to the well-being of others, then you just kind of catch a spirituality, whatever spiritual presence there is in the universe. Call it a source, call it presence, call it energy of God, whatever you want to call it. Call it the Holy Spirit. you come into life and your talents on what you can do to help others. So I just love this image, and it's kind of the image around here that our students really love, and we reflect on it actively, and people think about their day-to-day experience in this context. Okay, next slide. I think there is a next. Is there a next? Yeah. And just to finally end, this is the United Nations. So we actually filled the whole United Nations in August of 2016 on World Youth Day with students from all across this university, but especially the medical students were there. It was a celebration of love and an essay contest where young people from all over the world submitted essays about how they pushed back against pressure to hate other individuals simply because they didn't share their beliefs. So we had these winners, these contest winners from every corner of the globe. This took a whole day. It was incredibly exciting. Some of them did their performances by rap or folk music or whatever it might be. And then the next slide, we were, Ben, the next slide. Okay. Yeah, we were really blessed by having the great Pastor Otis Moss Jr., who is renowned. He was the head of the Institutional Olivet Baptist Church in Cleveland and a mentor of mine for many years. And he gave this beautiful, beautiful presentation. Next slide, if there is one, let's just see. Yeah, so that's basically it. So I simply wanted to make these dynamics clear, that it's possible to come into a medical system. Now, I came into this system in 2008 from Cleveland. I spent 20 years at Case Western Med. There was just bioethics, but the president of this university said, I want a cultural change in the medical center. I want a cultural change, because her own son had died of Hodgkin's, and she felt that neither she nor her family were treated with great empathy and compassion. And there was a lot of acrimony in the environment. So, with a little bit of faith and a lot of hope, we were able to, with the right people, many people helping out, we were able to create an environment that really did get recognized by the national bodies as they canvassed everybody in this system, that we had a community of compassion and spirituality, and that was a good thing. Thanks.
Dr. Post, thank you so much for sharing with us today. What a rich presentation. I'm going to have to go back through that and look at that again when we have the slides. Just so much to dig into and ponder. Lisa, if it's okay with you, I want to ask a question here of these gentlemen, both Dr. Post and Dr. Hamilton. As we were planning for today, one of the things that we talked about is the reality that so many psychiatrists went into psychiatry out of this vision of truly helping patients dealing with mental illness, with the challenges that accompanied that. And yet so many of them in the systems they work in have just become quarterly 15-minute med managers. Right. That's all they do. So they see their patients once a quarter. They spend 15 or 20 minutes with them. They might keep in touch with them via email in between, but basically in many systems, psychiatrists are just quarterly med managers. And I am really curious how the two of you would advise psychiatrists in those kinds of systems to encourage change in their own system. What steps could they take? Baby steps perhaps to incorporate spirituality and faith into their own practice, but also what could they do perhaps to challenge the system they're in to be more integrated?
Dr. Hamilton, do you want to try that, or would you wish me to give it a shot? I mean,
Dr.
I
Hamilton,
think,
could you?
Yeah.
Please. Dr. Hamilton, if you could come back on screen, we'd love to hear your thoughts on that.
If I might, Shannon, in my discussions with Dr. Hamilton leading to our event. Dr. Hamilton, you had shared some very interesting ideas on a vertically integrated instantiation of a culture of support. You have some very interesting ways of supporting every level to the point where I, as a client, am then touched by your culture change.
Am I back on now?
Yes.
Okay, good. So I think Dr. Post's story at the end was very revealing. Here was a family of a very prominent person in the institution who had an experience that was less than satisfactory. They might have gotten wonderful clinical care, but certainly the human side of that and the spiritual side of that was not met. And it led to a very significant decision at the top of that organization to say, we're going to change the culture of this institution. There's nothing like having the support of the senior executive leadership of an organization to empower people like Dr. Post and others who can come in under that umbrella and begin to implement ideas and programs and initiatives that make a difference.
Yeah, leadership is important, and giving physicians enough autonomy to schedule their day in a way that is consistent with their professional integrity. So, you know, here, for example, clinicians who know that they need to spend more time with patients, with some patients, but not with others, they'll schedule them later in the day, and they'll have a half an hour or even 40 minutes with them. Whereas the ones they schedule early in the morning may just want to be in and out. So giving clinicians some self-determination is important. You know, self-determination theory is all about creativity and about being able to manage your talents in the optimal fashion. I think it's really a key thing. It doesn't have to be the case that every patient gets their 10 or 15 minute slot. I don't know how Dr. Hamilton would respond to that, but we try to have some flexibility.
What we've learned with our physicians in our clinical mission integration program is that so many of them, literally hundreds of doctors, are now participating in our program, and it's nothing more than giving them permission and providing professional support and resources so that they can continue to do the work they do every day, but know that when they uncover an issue that needs to be addressed, that there's a process and there are people who can do that. That gives them comfort, and more than comfort, they embrace the program because they see what it does for their patients.
Yeah, it's a great point.
That's really good. Yeah, Lisa, did you have another question? I have so many that came in on the Q&A that I can turn to.
Okay, great. I'll just do one last, if I may. I think a very powerful theme in both of your presentations today is that to touch the heart of our patient, we need to support the spirit of our doctors. Mm-hmm. And I think you've both come up with innovative systems that, again, are vertically integrated so that no matter where I am in the organizational lattice work, I am spiritually supported in a way that is respectful of my unique way of being, my unique practice, and part of a community. I'm wondering if you might just add one word on what structures that you've built that are replicable, perhaps, that are actionable, have really stood out to you as most spiritually supportive of the physicians.
We had one physician who self-identified as an atheist who said, I wasn't very excited about this program, but now that I see what it's done for my patients, I understand them better. We had another one who likewise said, you know, I'm not a believer, but now that I see what this program has done in my office, he said, it's changed the culture of my whole office, and I want you to know that you are welcome in this office and in this practice. Pretty
And that
amazing,
makes,
I think.
it is amazing, and that makes compassionate care and care consistent with the most noble aspirations of the health professions possible. It makes team interactions so much better. So our circles of trust, which are small on, one by one, but when you bring them all together and have them overlapping, you really do create an overall cultural shift. Sometimes it waxes and wanes a little bit, and one has to be conscious about its strength. We're having SCHWARTZ rounds now on people's experience of the COVID epidemic and what that meant for them when they were coming home and fearful about conveying this illness to their loved ones. So we're just giving them a lot of time to process what they've been through, and that in and of itself will bond them together, because suddenly they're able to talk about these deep things. I'm sure we're actually doing that tomorrow. I'm sure there will be some tears in a big socially spaced room, and it'll all be on the web. But giving folks an opportunity to really talk about this in trust, in confidence, is the best thing you can do to galvanize them to provide care for one another. And from that flows care for patients.
Thank you, Dr. Post and Dr. Hamilton. And indeed, as Shannon and I were envisioning this series, it was in the past few months that it became clear that now more than ever, these partnerships are essential. Shannon, take it away.
Absolutely, yes. Thank you so much. We're going to go just a little bit longer because we had some technical challenges today. So let's take about 5 more minutes. A couple of questions came up that I wanted to ask you about. One asked how you bill for spiritual care. And obviously, if there's not a way to bill, then that creates challenges for systems. So in your systems, Dr. Hamilton, how do you bill for spiritual care in your system?
Well, the program that I referenced, we don't bill for. We actually early on in the program had a couple of providers who tried that, but we said this is not something that we'll bill for. We are fortunate, I'm fortunate in that the institution I work for is a faith-based institution that is very serious about its mission. When we started it, our company allocated $5 million annually to this program, and that allowed us to staff it adequately so that the doctors and the practices would be supportive. So billing, this is something we do on top of whatever else we do. It's part of our commitment as a not-for-profit faith-based institution.
So it's just mission driven in your case?
It's absolutely mission driven.
Dr. Post, do you do billing for your spiritual care in your system?
Well, the individuals who do clinical pastoral care do have compensation. They don't necessarily bill by a particular encounter, but they do have compensation.
Right.
We're not mission driven in the sense that we're a secular institution, but I find that this is a place that is particularly interested in becoming a compassionate healthcare system and is doing very well at it. Maybe it's just the luck of having the right people here at the right time by pure happenstance, but it's been very exciting. And we do have a history.
I would call that providence.
Providence, yeah. I mean,
not happenstance.
Yeah, Ed Pellegrino was the first dean of the school, and he was a great Catholic medical ethicist and clinician, and he cared about these things. And there are other people who have been here. Jordan Cohen, who was very well known for his writings on compassionate care. So it is part of the the narrative of the institution. I've been lucky to inherit that a little bit, but it's sometimes tough slogging, and you have to be mirthful, you have to be lighthearted, you have to be effective as an advocate, and you can't overwhelm people.
We want to tie up with one last question because this came up. Several people asked this question, and it's actually one near and dear to my heart because my dear friend now, Dr. Lisa Miller, is Jewish and I am Christian, and yet we are working on this together because we recognize that the research tells us that people benefit by having an integrated system that honors their faith belief. Now, some people from certain different denominations might be a little uncomfortable with that whole concept, and we just need to acknowledge that. And what I would say to friends who are a little uncomfortable with other parties and the way they would do it, you focus on incorporating the form of your spirituality into the care that you provide, because that is what we are seeking to empower here, is to empower you to live out more effective service to your patients, your clients, in whatever way you believe. So Lisa, I'd love to have you comment on that because we've talked about this some, and I think this is a little bit of tension that some people are feeling about this conversation.
Great. I think that you've said it beautifully, Shannon. We have a very strong clinical science that shows that a strong spiritual core is highly protective against recurrence, is essential for many people in recovery. So it's simply the case when we look across levels of analyses, twin studies, long-term clinical course studies, MRI studies, that we do have an innate foundational human capacity for spirituality. 1/3 innate, 2/3 socialized, environmentally enhanced. And when that is supported, recovery is far more likely, prevention against recurrence is far more likely, and we can point to what circuits in the brain run, if you will, as a docking station of spiritual awareness or spiritual connection. That said, the 2/3 embrace, the socialization, the environmental embrace of our innate spirituality is held in many diverse and wonderful ways. It is the embrace of our rich faith traditions, all of ours. For some people, spirituality exists outside of religion, in nature, with their family. But no matter how I might hold my faith, in our country, 2/3 of people say my spiritual life is held in my rich faith tradition. No matter how I might hold my faith, it is simply a scientific fact that a strong spiritual connection is curative, preventative, and the greatest source of resilience, even against the current epidemic of addiction, depression, and suicidality. Suicidality in young adults and adolescents has surpassed rate of death by auto accident. It's the #1 leading cause of death. So it is iatrogenic harm, in my view, to avoid the spiritual core, particularly when a patient is saying, yes, I want that support. What, in my view, makes it constitutional is that we locate the point of choice in the patient. So we are not insisting, we are not laying it on them. It is not a contingency of care. Yeah.
It's an invitation to them.
It's an invitation. It is an invitation.
To participate, absolutely. Well, you know what, I can tell from the few of us on this screen that we could go on for a lot longer because this has been such a rich conversation. Dr. Post, Dr. Hamilton, thank you for sharing some of your time with us today. We're very grateful for the expertise and the sensitivity and just the warmth that you have brought to this topic. You are showing us both head and heart in what you are sharing, and that really is how we are addressing the concerns that we're raising through this webinar series. As a reminder to our guests today, we will be sending out a recording for this. Hopefully by next time, 2 weeks from now, we will have worked out some of the technical glitches that happened today, and we'll be smooth and on course for our next webinar, which is October 13th. You will receive the link to register for that webinar when you get the email from us in this next couple of days. We thank you so much for joining us. It has been a privilege to share this time with you. Dr. Miller, always a joy. Thank you. God bless you all. Have a great day. We look forward to talking to you in 2 weeks. Take care.
Bye-bye.
Thank you. Goodbye.